Thalassemia, the sea monster. Welcome to the discussion on thalassemias. Let's talk about a case of a 2-year-old girl who was brought to the hospital by her parents with complaints of a large abdomen, constant fatigue, irritability, and poor appetite. On examination, the pediatrician noted pallor, jaundice, hepatosplenomegaly, and that the child was underweight for her age and height. Blood work revealed a decrease in hemoglobin, MCV, MCH, and MCHC, an increase in reticulocyte count, 10%. Peripheral smears showed a microcytic hypochromic blood picture with anisopoikilocytosis, numerous reticulocytes, nucleated RBCs, target cells, and basophilic stippling. We have already discussed the 4 differential diagnoses of microcytic hypochromic anemia in the previous session of iron deficiency anemia. This table is a summary. Please feel free to take a snapshot. To analyze the case further, biochemical tests were done. Serum iron, TIBC, transferrin, saturation, and ferritin were normal. Serum bilirubin was increased. Based on the above constellation of clinical features and biochemical tests, a diagnosis of thalassemia was suspected. Hemoglobin high performance liquid chromatography, or HPLC, revealed an increase in hemoglobin F, which clinched the diagnosis of beta thalassemia major.
Hey, before we dive deeper into this topic, let me remind you to like the video and subscribe to our channel.
So what is thalassemia, and how do we explain all the findings in this case? It is a hemolytic anemia attributed to abnormal hemoglobin production. The word thalassemia is derived from the Greek word thalassa, which means sea, as it was first described in the Mediterranean region. Adult hemoglobin is formed by 2 alpha and 2 beta globin chains. Mutation affecting genes that code these chains cause an imbalance in globin production. The alpha chain is coded by 2 genes on chromosome 16 and the beta chain by a gene on chromosome 11. The presentation and severity of disease depends on how many alleles are affected and whether there is decreased production of the globin or complete absence. Thus, thalassemia can be classified into beta thalassemia major, intermedia, and minor, and alpha thalassemia silent carrier, trait, HPH disease, and hydrops fetalis. Let's learn about the case we are discussing. Beta thalassemia major. This occurs when both alleles of the gene expressing beta globin are mutated. It leads to accumulation of unpaired alpha chains, and as we know, every alpha in a herd establishes their dominance over others. These alpha chains form toxic precipitates which damage the cell membranes of the erythroid precursors, resulting in apoptosis. This ineffective erythropoiesis decreases the levels of hepcidin levels, a regulator of iron metabolism. Iron absorption increases and results in secondary hemochromatosis by the 2nd to 3rd decade of life. Decreased hemoglobin A production leads to microcytic hypochromic anemia. The poor microcytes have a decreased lifespan and are knocked down in the spleen, leading to extravascular hemolysis, jaundice, and the raised bilirubin levels in this case. In an attempt to compensate for the anemia, extramedullary hematopoiesis causes hepatosplenomegaly, as seen in the 2-year-old girl. The marrow expands with erythroid hyperplasia causing skeletal deformities, overgrowth of maxilla with protrusion of teeth, frontal bossing. Depressed nasal bridge can cause chipmunk facies or Mongolian facies. Radiological abnormalities attributed to an expanded marrow include crew cut or hair on end appearance of the skull and rib within rib appearance. Constant efforts to produce normal hemoglobin depletes the nutrients in the body, leading to growth retardation, as evidenced by the underweight child in this case. Anemia is very marked, with a microcytic hypochromic blood picture, marked anisopoikilocytosis, with presence of many target cells. Target cells are abnormally shaped RBCs with a targetoid or bull's eye appearance. The surface area to volume ratio is increased, leading to accumulation of hemoglobin in the center, like a small puddle. There are many precursors of RBCs, namely NRBCs and reticulocytes in the blood. RBCs show inclusions known as basophilic stippling, which are multiple blue-purple granules representing ribosomal aggregates. All these findings were seen in the 2-year-old patient. Oral manifestations other than the facial skeletal deformities include spacing and flaring of anterior maxillary teeth, marked open bite, malocclusion, mucosal pallor, delayed pneumatization of the maxillary sinuses, iron overload causes discoloration of teeth, and xerostomia due to salivary gland involvement. Dental radiographs show several signs of bone abnormality, such as generalized rarefaction of the alveolar bone, thinning of the lower border of the mandible, short spiky roots, thin lamina dura, absence of the mandibular canal, and dental procedures for thalassemia patients require these considerations. Thalassemia patients experience slow healing after surgical dental procedures. There is a possibility of hypoxia if significant bleeding occurs due to existing anemia. Dental care is adjusted based on the patient's tolerance for the planned procedure on the day of treatment. Factors like severe anemia, iron overload, splenectomy, and weakened immune system increase the risk of infection following dental procedures, especially those causing bacteremia like extractions or scaling. Antibiotic prophylaxis is recommended for such procedures. Patients with acute dental infections like abscesses require urgent dental care and antibiotics as needed. All patients should have a comprehensive dental assessment before starting bisphosphonate therapy to optimize their dental health. Preventive dental advice should be given, emphasizing the importance of reporting any symptoms like loose teeth, pain, or swelling as soon as possible. Hemoglobin electrophoresis, or HPLC, is confirmatory, where hemoglobin A is reduced and hemoglobin F is increased. Beta thalassemia minor is a condition with only one mutated allele. Patients are asymptomatic or can have incidentally detected microcytic hypochromic anemia with target cells. They have a normal lifespan and do not need blood transfusions. Hemoglobin electrophoresis shows an increase in hemoglobin A2. Beta thalassemia intermedia, as the name suggests, have clinical features intermediate of major and minor. Alpha thalassemia can vary in severity from a silent carrier with a single mutated allele, thalassemia minor with 2 mutated alleles, HPH, and HP Barth's disease with 3 mutated alleles, and hydrops fetalis, which is a lethal condition in utero, where all 4 alleles are mutated and hence no alpha chain production at all. Treatment of thalassemia major include multiple blood transfusions with iron chelators to prevent hemochromatosis. Hematopoietic stem cell transplantation is curative. Sickle cell beta thalassemia is a condition where the patient has abnormal hemoglobin that is seen in both conditions. The sickle cell gene is inherited from one parent and the beta thalassemia gene is inherited from the other parent. Not exactly the inheritance a kid expects from the family, huh?
Pop quiz.
Hope you had fun learning with us. See you in the next session.
Think out of the box. Explore more such videos on our website.